you, everyone. All right, we're going to go ahead and get started. I'm going to share my screen for you, and Tammy has 3 cases, and then we'll move to Robin, which she has 2 cases. So give me one moment, please. Let's start with that one. Does everybody see that okay?
Yes, we can. Thank you.
Perfect. Thank you. Is this one okay, Tammy? Start
Yes,
on.
this is fine. So this is a 32-year-old male. He came in back in June. He was in long-term treatment, and he had only found out he had Hep C in May of this year. And he was an IV drug user. He also shared his supplies. His drug of choice was IV meth, but he said he used any drug any way he could get it into his body. He also had tattoos, one professional, one non-professional, and possibly had a sexual partner with Hep C. So he is about 9 months clean now. And he is doing well. So his comorbidities there: anxiety, depression, insomnia, vitamin D deficiency, smoker, obesity, and chronic low back pain. And there are his meds. And he has had his Hep A vaccines. He is immune to Hep B, and his surface quantitative was 971. So he is 68 inches, 203 pounds with a BMI of 30.9. And there are his labs: white count 6.6, hemoglobin was 13.2, platelets are okay, glucose okay, proton, creatinine, all right. His liver enzymes just very slightly elevated. His APRI was 0.421. Child Turco-Pugh was class A and a MELD score of 7. His iron studies were okay. Vitamin D is 58.8, and his HIV negative. His genotype was 1A, and viral load 17,600,000. His serum fibrosis was F0. His rheumatoid factor was quite high. He wasn't having a whole lot of symptoms. Hep B core negative, and his cryoglobulin was positive. That's the first time I've ever had a positive cryoglobulin. Is treatment naive, no cirrhosis. So I had suggested treatment with Mavorette for 8 weeks or Epclusa. And is there anything that needs to be done further with the cryoglobulin, or yes, I need some education on that.
I think you're at the right place.
Right.
Thank you so much. Does anybody have any clarifying questions for Tammy before we go into the recommendations? All right, no worries. All right, do you have any recommendations, Dr. Gilfus?
Yes. And see, it's so annoying. You just asked for clarifying questions and then I didn't ask, and now I have a clarifying question. So do you know how long he might have been dealing with the hepatitis C, like when his initial first use was? This is purely for my curiosity.
Let's see. I am not sure, but I believe it's been a good while.
And that makes sense to me. So, big picture, I guess, just to his treatment, genotype 1A, all options are on the table with just a few clarifying facts. So obviously Maverick 8 weeks, Epclusa 12. Zepitir, you'd have to do the polymorphism testing, so we're not going to suggest that one. And Harvoni doesn't really demonstrate any extra benefit in this scenario because you'd require at 17 million viral load, that's above the 6 million where you can do a shorter course. So you'd still have to do 12 weeks. So there's really no short course Harvoni in that scenario. Your question about the rheumatoid factor and the cryos, why I really like this case is this guy has no advanced fibrosis, if I'm not mistaken, right? He's basically no advanced fibrosis, yet he does demonstrate that he has chronic immune activation and is creating autoantibodies. And so remember that one of the ways you screen for cryoglobulins, probably the most cost-effective way, is via ordering a rheumatoid factor. So rheumatoid factor is just an antibody directed towards other antibodies. If that's positive, and then you can subsequently order cryoglobulins if you want, which you have all that stuff, and go from there. So what do you do with that when it's resulted? You basically know that this patient has a frustrated immune system. They're generating a lot of antibodies. Some of them are binding other antibodies. Some of them are precipitating out. That's what a cryoglobulin is. And they can activate the immune system and cause end organ damage in various areas. So they can be asymptomatic, number one. Number two, the most common place they will present with symptoms is going to be joints and skin. So if you see any little purple spots of vasculitic rash or joint pains, that can be coming from cryoglobulinemia. The other organ that tends to be involved is the kidney. So one of the things that I don't know that we routinely have you guys check, but a UA, and particularly looking for protein in blood. So you're trying to see if there's any cryoglobulin involvement of extra organs and stuff like that. This is a great patient to treat quickly and get this behind him for many reasons. But this is the patients who progress towards autoantibody production and then cryoglobulinemia. Remember, eventually, if you leave this guy for too long, he could get lymphoma. This is the patient who is at risk of getting a B-cell lymphoma eventually from that chronic immune activation. But anyway, you treat him early, he should be curable. And since he doesn't have any advanced fibrosis, you shouldn't have to do any long-term hepatocellular screening. But I like this case because it demonstrates something we preach all the time, that fibrosis does not always correlate with extrahepatic manifestations. And this guy doesn't have fibrosis, but he does have extrahepatic manifestations. And usually you don't see them in just somebody who's had it for a year and a half or 2 years. It's more 10 years or so. So anyway, cool case. I dig it.
Okay, and and he started using drugs at 18 and he started IV drugs at 26.
26. So we got about a 10-year head start, possibly, maybe.
Yeah.
Something like that. Okay.
Okay, thank you.
Did everything make sense about the cryos? It's basically just a marker that you want to treat this guy. As long as there's no end organ damage, nothing else to do.
Okay, thanks.
Thank you so much. Do you have any other questions before we move on to the next case, Tammy?
Nope.
All right, we'll go ahead and do so. I'll give you a moment.
Okay. Okay, this case is a 24-year-old male who came in for Hep C, and he was referred to me from another clinic. And he said he started smoking weed around 10 years. And then when he was 16, he started using heroin and meth. He said he started to use them IV very quickly. And then he was on the streets for about 6 years. And just finally, he said he just decided he was tired of living like that. He wanted to straighten his life out and do something with it. So he got himself into a Suboxone clinic and got a job, an apartment, now a girlfriend. And he has been a real inspiration to our clinic. He has non-professional tattoos. He has shared his supplies, and he has had sexual intercourse with a person who had Hep C. He is a smoker. He has GERD, anxiety, and insomnia. And there are his meds, omeprazole and quetiapine and Suboxone. He has had the Hep A vaccinations and the Hep B. He is immune. See, his weight is 153, height 66 inches with a BMI 24.7. There, his labs: white count 6.3, hemoglobin 14.5, platelets 222. His kidney function is good, blood sugar 87. His liver enzymes 78 ALT and 44 AST. His APRI was 0.495, child Turco-Pugh, class A, with a MELD score of 6. And his vitamin D is good, HIV negative. He is genotype 3 with a viral load of 2,430,000. His fibrosis marker was 0.28 or F1. Hep B core antibody was negative, cryoglobulin 0, and rheumatoid factor was less than 10. He is treatment naive. So the treatments that I saw that he could take is Mavorite, Epclusa, or Vosevi.
Thank you very much. Does anybody have any questions? All right, Dr. Gilfoos, do you have any questions?
No, actually this time not. Great job. Hey, and thank you, by the way, for reporting the hepatitis B surface antibody quantitative number. That makes me feel better. Remember, anything greater than 100, you feel good about.
Right,
So,
right.
yeah, doing well there. So this guy has about 8 years potential exposure at maximum to hepatitis C, genotype 3. Now, and great job. I can see your thought process. He does not have cirrhosis, so there's no need to worry about doing baseline resistance testing for this genotype 3 patient. Remember, the genotype 3s are the ones that we do contemplate doing baseline resistance testing on, where for that one special mutation that I'm not going to say because I'll mess it up, but we would consider doing it if the patient was cirrhotic, but this one's not. So the only thing I see here that leads me towards one drug or another, and I got Rachel on here, but the issue is the omeprazole and the valproate component of Epclusa. That's a potential issue. If the omeprazole is necessary, you just have to take it 4 hours before? Isn't that what it is, Rachel? 4 hours before the omeprazole or something like that?
So you got to take the Epclusa with food and then the omeprazole 4 hours later, and that dose is appropriate if the 20 milligrams. That's the maximum they recommend.
Perfect. Or you could just bypass that altogether and go to Maverick.
Right. Okay.
Yeah.
That sounds good.
And the Vosevi is a cool thought. It also I think has valpadosphere in it. So it would, I can double check that real quick, but Rachel, can you, is that, it's got valpadosphere, I think, still?
Yeah, it's just like Epclusa, but it has the
Extra
voxeloprevir protease inhibitor in it.
Yeah. So, and Vosevi would run the same issues then with the drug interaction with omeprazole, number one. And number two, it'd be nearly impossible to get. It's really a drug for treatment failure for the most part. So it's one that if you have baseline resistance and you don't want to use ribavirin, or you have a treatment failure, that you'd go there. But cool. Hey, another good one to treat quickly because it's genotype 3. He's already 8 years down. Fortunately, not a lot of fibrosis. But remember, genotype 3 might hit him earlier than other genotypes with significant fibrosis. So good time to treat him.
Okay, I'll do that.
Great job. Thank you, John. Thank you, Rachel. That was just so helpful. All right, you ready for your next one, Tammy?
Yep. Thank you for letting me do 3 today.
No, it's our pleasure. Thank you for having them.
Okay. All right. So this guy is a 42-year-old male. His first visit was in June. He had also just recently found out he had Hep C. He started smoking crack at about 18, used IV meth for about 2 years, but none since June of 2020. He had heavy alcohol use, which was his preferred drug of choice, but he's on antabuse now, and it works for him. He thinks he might have gotten Hep C from tattoos. He has a lot, but most of them were non-professional and in jail. No blood transfusions, may have had sex with someone who was positive for Hep C. So his comorbidities: depression, erectile dysfunction, recovering alcoholic, and he had a low iron level. And there are his meds: bupropion, disulfiram, sildenafil, thiazole, and vitamin C. He is also immune to Hep A. And he wasn't on that first date immune to Hep B, but we have done his Hep B vaccines, and I might have gotten another Hep B. I'll check that. But his weight, 133, height 63 inches, BMI 23.6. And his labs, his white count is normal, hemoglobin, hematocrit normal, kidney function okay, blood sugar 106, PT and INR good, liver enzymes were all right. His, whoops, I think I missed his APRI, but his child Turco Pew was class A and MELD score of 7. And there are his iron levels, HIV negative. His genotype is 2B with a 10,100,000 viral load. His fibrosis marker is 0.03 F0. No cryoglobulin, rheumatoid factor negative, and Hep B core antibody negative. So the best med for a 2B, Mavorite or Epclusa.
Thank you again. Great job. All right. Does anybody have any questions?
And no questions, but man, this is cool. You got all these weird genotypes.
I know. Yeah.
Yeah, you know, genotype 2 is not one of the scary ones. It's classically the one we like to see the most. Even pre-direct acting antiviral days, this is the one we would celebrate because it was a shorter treatment duration for interferon, and actually interferon worked. You know, we could cure 90% of these people. So we liked it. And, you know, it's the same for the direct acting antiviral world. We don't fear this one that much, as long as you pick the right drug, and you're picking the right drug. I think there's no APRI because I don't see a platelet count. Did I miss the platelet count?
Did I miss that? Let's see. Oh, I know what it was. When he was referred to me, he had just had a CBC, but the provider didn't order a differential and no platelet count. So that's why.
Totally makes sense. Yeah, and I
Yeah.
got you. Yeah, and
Yeah.
you know, were there any suspicions in this fella for advanced liver disease? The platelet count would certainly be an important one. And big picture, if you ask me, what's the most important lab test outside of the transaminases for our patients? It is probably the platelet count, just because it can give us a good sense of cirrhosis, number one. And remember, patients with Hep C also can have autoimmune phenomena, including ITP. So anyway, platelet count is on his wish list at some point. But I doubt that he's cirrhotic. You know, he's certainly got a comforting F score, and you got an ultrasound, I think, that didn't suggest there was much going on with regard to a tiny little lobular liver or anything like that. So I feel comfortable treating him as a non-cirrhotic, and you know, your 12 weeks of Epclusa, 1 pill once a day, or your 8 weeks of Maverick would be fine. I don't, at least to my eyeball test, see any issues with drug interactions. And Rachel, I'm sure you can correct me if there's anything there. And he's just like the last case. I forgot to mention this in case 2. Neither that one or this one is going to require long-term HCC screening, because neither of which we think have advanced fibrosis. So no F3 or greater. So once you treat these patients, you're done. And my compliments about all your vitamin D levels, by the way. There must be some special sunshine over where you practice. It's only normal vitamin D levels I've seen in West Virginia. So that's good. Either that or you're replacing them effectively. So
Yeah.
Otherwise, good job. I think that's a pretty straightforward one, as long as we can at some point get a platelet count and it's not like super low.
Okay. All right. Thank you very much.
Go ahead, Rachel. I see that you unmuted.
I was just going to chime in that there's no drug interactions at all. So your eyeball test is good there, Dr. Gilfus.
At 20/20 vision, you're good. Thank you so much, everyone.
That changed after age 40. That's
All right, Tammy, are you good? Do you have any other questions before we move on to Robin?
No?
Thank you again.
Everything's
Really
good.
appreciate it. If you do, just let us know. All right, Robin, are you ready?
I am.
Perfect. I'll pull that up.
Try to turn my camera on. There we go. Okay, so this is a 30-year-old female. She feels like she probably got infected with hepatitis C when she first used drugs. She was diagnosed about 10 years ago, but I think she started using really early, like about the age of 15. She currently lives in a transitional living facility in Bluefield. She's recently got a job at one of the local fast food restaurants, and she's planning on being in this transitional living home she originally said a year, but I think she's hoping for more than a year. She does have a 10-year-old daughter in custody of her paternal grandfather, and her father still uses drugs, so she tries to stay away from him. This patient does have schizophrenia, but it's very well controlled. She sees a psych provider here at the facility where my office is. She's not currently on birth control. She does have a few psych meds, and I'm replacing her vitamin D. She's on famotidine, mirtazapine, Buspar, aripiprazole. She is immune to hepatitis A and B. Her hemoglobin was good at 15.4. platelets 333, creatinine 0.8. Her liver enzymes are in acceptable range. Her APRI score is 0.330. Iron was 97. Her stored iron is 58. She's genotype 1A. She was I think her meal score was 6, and her child Turco-Q was class A. I think probably that she would do well on Maverit for 8 weeks. Oh, I did get a liver ultrasound on her too. She did have some tenderness in her right upper quadrant during her physical exam, and so I got a liver ultrasound, and it was essentially unremarkable. A little bit abnormal echo texture of the liver is all that was really identified, but everything else was normal.
Thank you very much. Any comments or questions for Robin's case?
Hey, Robin, it's John Gilchrist. Thank you for presenting. That's awesome. So this lady might have had up to 10 years of infection roundabouts, it sounds like, but no significant fibrosis, thankfully, and that's wonderful. So she was genotype 1A, right? Yeah, genotype
Yes.
1A. Okay. So all the treatments are on the table: the Harvoni, Epclusa, Zepitir, and Mavorite. And as with the genotype 1As, we seldom go to the Zepitir because it requires that extra step of testing. Harvoni times 8 weeks would be an option for her as well, just theoretically, because she's less than 6 million viral load. So if you kind of look for the two shortest options, it would be Harvoni times 8 weeks, 1 pill once a day, or Mavorite times 8 weeks, 3 pills once a day. And Epclusa, 1 pill once a day for 12 weeks is also an option. Now, when you look at her medicines, you do see that she's on an acid suppressing medicine. We tend to be talking about PPIs most of the time, but there's still issues with H2 blockers. And I actually had to look this one up, and probably Rachel can help me on this one too. But from what I was reading is you had to either take the H2 blocker at the same time as the Epclusa or separate it by 12 hours. And Rachel, do you want to correct me on that one? I mean, we don't talk too much about, we tend to be, everybody's on PPIs nowadays and not H2 blockers, but
Yeah,
concept.
and that's correct. It depends on how many times they're taking it, whether it's the 2 times a day or 1 time a day. So you do have that option of doing it simultaneous, and then also 12 hours later. So if they are taking it once a day, you could separate it out, but the kinetics are okay if they take it simultaneously too. So it can kind of go along with their normal routine, so long as it's not more than 20 milligrams twice daily. That's the cutoff for the famotidine.
Okay.
Yeah, and same would be true with the Harvoni. So both Epclusa and Harvoni have that sort of issue with requiring good stomach acid. So Mavorite might be the easier one. The only issue I'm going to mention with Mavorite is that she is of like child potential bearing age. And if she did go on, so obviously one of the tests to get before you start her on treatment, just because we're not sure on the safety of any of these, is a beta HCG test. I know that some of my colleagues have diagnosed people with pregnancy unbeknownst to them prior to initiating therapy. And then if she were to go on a birth control medication, Mavorite could interact with the non-progestin birth control medications. And again, I'm going to kind of hand that ball back over to Rachel, since that's her. She's much better at that than I am.
So you're saying she'd need a progestin only?
That's
Correct.
Correct.
Okay.
Yeah, so the Mavorite has that contraindication with anything that contains ethinyl estradiol, which is most of those combined hormonal contraceptives, causes those increases in the ALT. So they're contraindicated to be given together. But you got a lot of options, whether it's the mini pill, the progestin-only pill itself, or you can do a lot of the implants and the depot shots are all progestin only. So those are all valid options with the Mavorite.
Okay.
The only thing that I would bring up with the Mavorite, it's not a contraindication. It's one of those monitoring things. If you would go with Mavorite, is the aripiprazole. And it's just to kind of monitor for increased risk of adverse effects because the Mavorite prevents the elimination a little bit of the aripiprazole, which kind of has a narrow therapeutic index. So usually what I see most common is patients notice a little bit more of the sedating effects. Since it's only 8 weeks, you don't really have to worry about the metabolic stuff with it. So it's just kind of, be aware of it. There's no adjustments or anything. It's not a contraindication, just kind of watch.
Okay. All right, I'll do that.
Great, thank you so much. Do you have any other questions for that case, Robin, or do you want to move to your next one?
I don't think so. I think I'll go with the Mavorite. That sounds like the simplest solution. And I don't think she's going to be on birth control. I don't think she's going to be in a relationship, but I'll double check with her. How often do you recommend if I do the Mavorite? I mean, do you all recommend that I do pregnancy tests, once a month, or not worry about it after I did the original test?
I think if you educate her, if she's somebody that you trust and have a good relationship with and communicate that way, honestly, we just used to do them before initiating people on therapy. And it's, there's not documentation of harm with these medications. It's just a big unknown. And so, there's trials coming. I think COVID sort of, Dr. Feinberg, one of our other staff here is more privy to some of the clinical trials that are going to be launched in pregnant patients. But this is something we're just cautious about, perhaps overly so due to the bad history of some of the old Hep C therapies. Ribavirin containing regimens is clearly a teratogenic potential. And I think all of us in Hep C care a little bit chicken because of our experience with the ribavirin days. And even back then, it's not like we made people get pregnancy tests routinely while they were on therapy. We just kind of educate them heavily that, hey, this isn't safe, don't get pregnant, and so on and so forth. And I think that's all you got to do for her if she's trustworthy and stuff like that.
Okay, yeah, all right, I'll do that. All right, so my second case, this gentleman is 52 years old. He became addicted to drugs when he was injured in a work-related accident. It was a crush injury, and now he is in the Suboxone program. So his last IV drug use was 4 years ago. He does have several unprofessional tattoos. Along the way, he's gone to jail a few times, but I think right now he's doing a whole lot better. He has COPD and hypertension. Both are controlled on his current medicines. He is immune to hepatitis A. He apparently was exposed to hepatitis B because his core was positive, but he has developed antibodies, so that's reactive now. He's about an average BMI. All his labs are, relatively normal. Platelets were 255. His liver enzymes are in acceptable range there. His APRI score is 0.412. His iron is within normal range. He's a genotype 2B. His fibrosis stage was at F2. So, I'm also thinking Mavorite for him too for 8 weeks. I don't think he'd need 12 weeks. So I'm thinking 8 weeks of Mavorite would be acceptable for him. So what's your all suggestion on that one?
Thank you so much, Robin, again for a wonderful presentation and case. Any comments or questions?
Hey, Robin, do you know how, what the potential longest amount of time the patient might have been using? I know they haven't used it for a while. Do you know when they might have started?
I don't know exactly when his accident was. I think it was about 20 years ago. So I think he was, hardcore using for at least 10 years, but I'd have to touch base back with him to tell you that for sure. I see several and I get them they all kind of run together.
Yeah, that fits. He's interesting because of all the people presented today, I think this patient potentially has had hepatitis C the longest, and as the only one with a little bit of fibrosis.
Right.
F2 there on the fibrosis marker. Platelet count's comforting. I clearly don't think this guy's cirrhotic, and we're just missing it on a serum fibrosis marker. And how cool is this? He's out of the 5 patients presented today, 3 of them have been weird genotypes. So the genotype 2B, and again, this is not a scary genotype, either with natural history or with being more challenging to treat. Genotype 3 is the one that holds that distinction. So yeah, no, I love your choices. Mavorite 8 weeks would be the simplest. Epclusa for 12 would be the other option. I don't see any issues with his meds, and only thing I wanted to do is compliment you actually on your interpretation of the hepatitis B serologies. We harp so much on if the core is positive, that's the version to take pause on, but you're 100% correct that if the surface antibody is positive, you don't have to worry. So that's the situation. This guy's got natural infection and natural immunity and is good. And so he's not anybody who's going to require any special monitoring after you treat him for his hepatitis C. It would be a whole nother ball of wax if the antibody to the surface antigen was negative. Then this would be that scenario that we worry about. So good job. Excellent recollection of who you need to worry about and that it's not this guy. So he, with his duration of infection and the some fibrosis score, one of the things you might want to do is an ultrasound at some point just to make sure we don't have some disparate data point where you get a picture of his liver and it's a shrunken little scar. Very unlikely, but just always want to make sure that we don't put too many eggs in one basket. And I don't think we are, but just like to make sure. Sometimes in people like this too, I'll check a fibrosis score after treatment and see if it gets better. I bet you his serum fibrosis score largely reflects his elevated transaminases, but time can tell that one. But I'd go ahead and treat him. Nothing really spectacular on that one, and that I would worry about. And just good job. Excellent.
Thanks.
Thank you so much. Does anybody else have any comments or questions for today's session or announcements before I do our final announcement for the day? We might get some time back. I didn't think that was going to happen, but we did great.
I just
Can I
wanted
ask a
to,
general question?
Sure.
Sorry.
No.
I'm starting hepatitis C treatment, trying to get everything set up for my clinic. Can you just tell me the basic lab, the labs you generally order pre-treatment? I've seen so many different resources and I'm kind of confused.
Yeah, hey, Gary, great question. One of the beautiful things about submitting cases to ECHO is as you populate the submission form, it's kind of a good reminder of what labs to check. There's probably, and this is something that I've personally meant to add for a little while. The only labs besides the ones we talk about on these cases is probably we should have a TSH built on for most patients because hypo and hyperthyroidism is not uncommonly associated with hepatitis C. We probably should have an A1C because glucose intolerance tends to run with hepatitis C, and probably a urinalysis. But everything else that you see on the labs, just routine CBC, chemistry panel, liver enzymes, and then looking for hepatitis A and B co-infection, HIV co-infection. I tend to throw an RPR on there too, just because risk behavior tends to run together. And then, all of your sort of fibrosis estimates. So usually that's done with a serum fibrosis score. And then, I'm kind of going off of memory right now, and that's always a bad idea. And genotype, of course, genotype. So, but yeah, if you practice filling out a couple of these with the ECHO form there, it's both great for submission and also good for your own practice, recollecting which labs to to check. I guess if it is a female of childbearing age, probably a beta HCG too, since I mentioned that today.
Thank you so much.
Thank you. Great question. And we do have that link in the recap as well. And I think that Mitra just attached it. And maybe we could see about making those changes and adding those tests to the form as well, Dr. Gilfoos.
Yeah, sorry about that. I just like the first
Oh,
time.
no.
And by the way, Gary, it depends what resource you read. If you read something written by a hepatologist or a GI doc, you tend to get a lot more lab tests ordered. So we don't tend to order a ton of extra screening lag looking for autoimmune hepatitis or any primary biliary cirrhosis or Wilson's disease. And we do iron studies at baseline, as you'll see on the lab, just because hemochromatosis is so common. But the two major approaches is you're going to do the broad screening first, and then see if you catch maybe multiple etiologies of patients' abnormal liver function tests, versus the approach that we tend to use more in ID, and that's we just treat the hep C and then only worry about looking for secondary causes if the transaminases don't normalize. And neither way is right. It's just different approaches.
Okay.
But absolutely, I agree with you. I've read some resources that order a lot more autoantibodies and sort of hereditary disease screens at baseline than we talk about on here.
Thank you.
Great. Thank you so much. Does anybody else have any questions before we end for the day? All right. So our next session's actually canceled because of Thanksgiving. So we'll see you after Thanksgiving. If you celebrate that holiday, hope you have a really good time with your friends and family. If not, still eat some turkey because it's delicious. And then our next session will be December 9th with Angela Wojcik discussing medication regimens. So have a great holiday, and we look forward to seeing you guys in December.
Thank you.
Thanks, everyone.
Bye.
Lindsay.